service, and perhaps your.
Thank you, Karen. Yeah, I think it's quite an applicable quote, regardless of your beliefs. Should we move on to the first agenda item, which is enhanced access? We've got Paul and Isaac from NHC, and we've also got Jenny to just give us an overview and an update on the local access plans. We did invite Vijaya, who's the chief executive of the GP Co-op, to attend, but she has some prior engagements. But if anyone is from the co-op, from their board, or wants to contribute during the consultation, then please raise your hand and we'll get round to you. Paul, I'll pass on to you.
Brilliant, thank you, Nadeem. Hello, everyone. Before we get started on the enhanced access, I just wanted to share a slide about data sharing arrangements and agreements. So we're undertaking a number of different activity services across Newham on behalf of practices and practices on behalf of other practices. Now, post-COVID, the sort of legal requirements have subtly changed. They were relaxed during the COVID period around data sharing. So we conducted a review and are putting together a data sharing agreement for practices within Newham to sign up to, and it's only for primary care. It doesn't include other sort of system organisations. And that document is currently being reviewed by the LMC and should be ready for sort of circulation and sign off by practices in the next couple of weeks. But I just wanted to highlight that it's important that we have a good governance framework for the way that we share data within Newham. So that this is what the purpose of that document. So just to highlight, that is coming and it is being reviewed, and we're getting input from the LMC, which is great. So just to highlight that. I'm going to hand over to Jenny now to just sort of give an update on where we are with the enhanced access service, and then I've got a slide about some of the practical things around the mobilisation that NHC is doing with the PCNs that we're working with. But hand over to Jenny.
Thanks, Paul. Maggie, do you have my slides, please?
Yes, just getting them up.
Thank you. Thank you. So I wanted to kick off by thanking everybody, practices, PCNs, CDs, practice managers, and everybody who's been involved in putting together the submissions that came into the ICB on the 31st of July, and also to those who have attended the clarification meetings we held after we received the submissions. So the piece of to try and land this service, one of the key things we did back on the 9th of June is we held a workshop with the PCN CDs. So John Rook, our borough director, led that workshop. And as part of our discussions about what an enhanced access service might look like, we discussed a number of principles around quality of care, access, workforce, equity, and there's a second slide as well, if we could move to that one. So value for money, resilience and support, and information sharing. And Paul has really helpfully touched on the data sharing agreement arrangements that need to be established to make sure that we're working within the correct governance arrangements. So in considering the submissions we received from PCNs, we were very mindful of that discussion, and it was a really helpful discussion on the 9th of June, and those principles as we considered the plans that we received. So moving on to the next slide. So I know the map is not hugely clear, but we wanted to, or what I wanted to show you is that, so what we received was, so as you know, we've got 9 PCNs in Newham. What we received was a proposal from 1 PCN to deliver the service themselves, from 2 PCNs to deliver the service by subcontracting it to Newham GP Co-op. And then the remaining PCNs, so the remaining 6, wanted to work with NHC to deliver the service either in part or as a fully subcontracted model. As part of the proposals, we received a suggestion that 18 hub sites would be established from which this service would be run. And those 18 are shown there. I think we are still waiting to hear back from North East 2 definitively about which site they're going for, but we've listed all of the proposed sites there. And that is, so what it gives us is a really good geographical spread across the borough. So is very accessible for patients, but we do have a couple of concerns about what has been proposed. So we've got 2 hub sites, which are probably about 30 seconds walk from each other. And when we start to think about how we mitigate the capacity gap that is going to be left from the 1st of October by the introduction of this new service, there is also, I think, an issue for us as a system and as primary care in Newham about whether establishing 18 hub sites specifically for this service is sustainable and resilient if we also have to mitigate the gap. And I'll come on to saying a bit more about that in a moment. So that's the proposal that we received. We had meetings with each of the PCNs and various CDs and their practice staff and subcontractors came to those meetings. They were really, really helpful in terms of helping us understand exactly what was being proposed. And therefore, for Newham, I was confident that I was able to go to the ICB and recommend that all the Newham proposals be approved for go live on the 1st of October. The 2 caveats that I've that we discussed, though, as part of that approval, the ICB approval process, was that that area I've already mentioned about is having 18 hub sites sustainable in the longer term. And the other specific issue was around the patient offer. We've confirmed to each PCN now that they have been approved and that we will continue to work with them, and many PCNs have submitted. I think all of the Newham PCNs have submitted now their mobilisation plans. So we'll continue to work with you and your subcontractors to understand any support you need and any risks and issues that may impact on service go live on the 1st of October. So as well as that discussion about the sustainability and resilience of what's being proposed in terms of those numbers of hubs and whether it does make sense to have 2 hubs within 30 seconds walk of each other, there is also a discussion to be had about whether the plans in terms of our patient communication and our resident communication make sense. As you can imagine, we've got 9 PCNs, we've got 18 hubs at the moment. We've got, because of the three kind of distinct arrangements I described at the beginning, so the one PCN doing it on its own or delivering the service themselves, the 2 who were subcontracting to the co-op, and the remaining 6 who were working with NHC to deliver the service. I think there is further work that we need to collectively do to be able to be very clear with patients about where they will go and what they will do come the 1st of October. And of course, that will need to be something that you talk to your staff about so that they're clear, and we'll also, and I know Paul will come on to this when he gives his update, we also need to think about what that means in terms of the message you will put on websites and your answer phone messages and that kind of thing. So the other significant piece of work we have been doing is to understand what has been proposed in terms of standing up the service by PCNs and what that leaves us in terms of a gap. And some of that we would have known in advance because of the very clear service specification that NHS England would have published. But some of it became clear as we saw the submissions from PCNs. So effectively, we currently have a PCN extended hours access service, and we have a primary care 7-day access service. And the new enhanced access arrangements is supposed to be a consolidation of both of those services. However, for Newham, we know that what we currently have is a service that works through till 10 o'clock, Monday to Friday, and starts at 8 o'clock in the morning and runs till 8 o'clock at night on a Saturday, 8 to 8 on a Sunday, and covers bank holidays as well. And these are all potential gaps that are going to be left by the new service. Lots of PCNs told us that they were really going to focus on core general practice, an extension of core general practice, and therefore more routine and chronic management, and that is absolutely perfect. However, what we see at the moment in this services that we commission is a significant amount of same-day urgent access that patients are asking for. And a lot of that will come through 111. And then, of course, the service specification at the moment relates to patients registered with your practices, so there's also a gap for unregistered patients. So moving on then, was that my last slide?
That's the last slide, Jenny.
Oh, that is the last slide. So, so going really well in terms of mobilising the existing service and working with PCNs to understand the support that they need. There is a particular risk around IT interoperability in that NHS England have not been entirely clear with us about the final arrangements for this service, and I think we have to stand up as best we can what needs to happen to deliver the service, but that may change over time, and we'll continue to make you aware of what if any further guidance comes out around that. Paul is going to talk to you about the subcontract, although I've shared that with all the PCN CDs. The other thing we haven't shared with you yet, but we will need to do so, is there is actually a directory of service form that each PCN will be asked to complete, so that 111 will understand what they can and cannot book into your service going forward. But I can talk to colleagues more about that at our operational meeting on Wednesday morning. And I'll hand back to Paul.
Brilliant. Thank you, Jenny. Does anyone have any questions for Jenny before I talk a bit more about the implementation? No?
Greg's asking a question. or is that a comment? Jenny, do you have a look at that question? Not quite sure I understand it.
So we are looking to fund the gap, but we haven't agreed how we will do that yet.
But the gap, Jenny, is not about the number of appointments. It's about the timing of the appointments, I believe. Is that correct?
It's timing, it's about unregistered patients. So it's all those things that I mentioned on that slide. And it's about that 111 same day urgent capacity.
Karen?
Yeah, so I just wondered, Jenny, given your question around hub sites, around comms to patients, and then potentially around additionality to this issue, just how, I mean, some of these decisions I know are out of, we're waiting for determination at NEL or whatever, but how are you taking it forward? Is there a scheduled conversation? Do we need to set something up? I'm just keen that I'm sure, you know, 1st of October is not long away.
I know it. No, it really isn't. Yes, we'll need to. We're doing some internal work at the moment, which we should be able to finalise at the beginning of next week, and then come out to existing providers. But you raise a very good point, Karen, because at the moment, you know, PCNs are delivering some of this themselves, some of it they're subcontracting. We definitely commission the primary care 7-day access service from you. There's been a switch in that many PCNs are subcontracting to you as well. Is there enough capacity and resilience in the system in order to be able to deliver all of this going forward? And that goes back to my point about the 18 hubs.
Okay.
Yeah, thanks.
Thank you. Manuel?
Yeah, I don't know if I missed something here. I mean, do we have the number of unregistered residents in Newham? Because at the moment, this enhanced access is funded on the waited list size of the PCN. And maybe, just a suggestion, if we know the numbers, whether NHC could have times whatever is 644 or 744 times the unregistered number of residents was still there to give that extra capacity to see the unregistered patients.
Thanks, Manuel. Okay, Jenny, I mean, you can get back to us about that at some point. I'm sure you're going to...
I think it's for commissioners to decide, really, isn't it? And have those appropriate conversations with providers about it. Yeah. Greg, you've got your hand up.
Yeah, sorry. It was just to say that NEL were very definite when I spoke to them that they have approved the funding and the extension of contracts for the existing service until the end of March. So it appears to be kind of a different, maybe, understanding about what has been agreed and what hasn't.
Okay. So the funding has been agreed. What we haven't done yet is had that conversation about how we are going to deploy and mitigate that gap between now and the end of the financial year. And I'm happy to have a separate conversation with you, Greg, if that would be helpful.
Yeah, I mean,
because
it's one of those things, isn't it? I mean,
yeah,
talking to NEL, they were very definite in saying that.
Yeah, we can take this outside this meeting.
I just want to make this clear. Mitigating the gap involved extending the existing contracts.
Yeah, that's fine. Thanks, Greg. But Jenny, I think we'll take this outside. Is that
okay.
all right?
Yeah, that's fine. Thanks.
Okay. Paul?
Yeah, can I just have the next slide, Maggie? Thanks. This slide, I just want to highlight some of the activities. So we're obviously working to the 1st of October target date for the commencement of the services. As requested, we've submitted a mobilisation plan for each of the PCNs. That plan covers a kind of Gantt chart project plan detailing all the different elements of the service to be set up, who's being responsible in the timelines. I've just done a very small diagram of taking a snapshot of one. It also includes a comms and engagement plan. So for each PCN, we've set out responsibilities of the key stakeholders, be it the member of the enhanced access team at NHC or the practice, or you know, other members of the team. And so we've got identified, you know, who is going to provide information to go on the websites, the telephones, etc. So we've got that comms plan, and there's also a risk register as well, where we've gone through and looked at all those risks to the delivery. So we've set that out. So for each PCN, there is a specific mobilisation plan. So if anyone wants to see their mobilisation plan covering their practice and they've not had it, please let me know, and we'll get that sent to you. But that has been submitted and shared. One of the other activities, main activities that we're doing in the preparation is doing hub site visits and audits, making sure that they're all fit for purpose and have got all the right equipment, etc. And alongside that, putting in place a very clear room hire SLA around the use of the space in each of the hub sites. So that will then be incorporated alongside the subcontract. So what we'll be looking to do for each hub site, we will ask them to, we will require them to enter into a SLA around the use of the space, which will set out everyone's responsibilities. So that'll be important when we're, you know, being assessed from CQC. And again, it's kind of good governance. We need to have that SLA in place. So that is one of the main activities that's happening. And then finally, the subcontract. So this was prepared by NHS England with input for lawyers and has been circulated as a template to be used by all the subcontractors delivering the enhanced access on behalf of practices and PCNs. So we have amended that, and we're just in the process of just reviewing and making that fit for purpose for each of the 6 PCNs. So that will be circulated next week to each PCN, and within that, each practice has to sign the subcontract, not, for example, just the clinical director on behalf of the PCN. So we will require every practice that we're delivering that service for to sign up to that subcontract. And within that, not only does it talk about room hire responsibilities, it talks about terminations, payment schedules, also data sharing, processing arrangements as well. So it's a very thorough and is a vital document to make sure that the service is managed correctly, and it clarifies everyone's position. So that we will need signed before the 1st of October. So that, as I say, will be circulated to the PCNs next week. So that's what I really wanted to highlight. Any questions?
Can't see any question, any raised hands, Paul, and no questions in the chat bar.
Brilliant. Anything
you want to add, Karen or Jenny?
And only to say, if questions occur to you after the meeting, obviously just drop us an email. Paula is on leave this coming week, so Paul will be happy to pick it up in conjunction with Isaac and the team, or, you know, obviously reach out to me or Jenny if you want.
Yep, and the funding gap, we can discuss that side of this meeting.
Yeah.
Okay, thank you, Jenny and Paul. Thank you. Hi, Laura. Laura's our one of our GP partners from Tollgate, and also the NEL digital lead. Shall I leave it to you to organise to introduce your fellow presenters?
Yeah, of course, no problem.
It's about repeat prescriptions. I'll hand over to you now, Laura.
No worries at all. Thank you. Yeah, so I'll introduce Joe, and then at the very, very end, Charlie's going to come on and talk about a slightly separate project, just for a few minutes, if that's okay. So this is a digital accelerator project, and Joe's the project lead on this project about NHS app repeat prescriptions. So I'll hand it over to Joe to start presenting, and then we'll share it from there. So Maggie, if you can go to next slide, that would be great. Thank you.
Thanks, Maggie. And if you go to the next slide. Hi everyone, I'm Joe Caracal, as Laura mentioned. We are running a project across North East London, starting in Newham and City and Hackney, supporting practices to increase the use of the NHS app for repeat prescriptions specifically, as part of the Digital First programme The reason for this is that approximately each month there's around 114,000 repeat prescriptions requests that come in within Newham, and only around 8,000 of those are ordered via an online method, either through the NHS app or through patient access or other online systems that are available. So we have done a kind of pilot in Tower Hamlets previously, which estimated and looked at the impact of manually processing repeat prescription requests, and largely when they're made in person, over the phone, or through your existing online consultation system, whether that be EMIS, AccuRx, eConsult, etc., they all require some kind of manual intervention from your reception team to then enter them into the clinical system. And so that's quite a manual process, and really by increasing the usage of things like the NHS app and helping patients to order them online, we're hoping to streamline that process and ultimately save time for practices, save particularly reception time, which they can use for other tasks, whether that be things like QI projects or to support those patients that are not able to use online methods for whatever reason. We're not through this project trying to get everyone to use the NHS app. We realise there will always be a patient population that can't use it, but it's trying to, how can we free up the telephones, which I think we know from the patient survey is a big issue for a lot of patients across North East London, and give them other ways to increase their access and streamline and reduce the workload at practices to focus on other kind of other tasks. So if we go on to the next slide, I'll invite Laura as well to kind of come in on this, but alongside that kind of main benefit of trying to reduce the workload for frontline teams, it also offers kind of patients more choice. They can complete that request at any point in the time. They don't have to come into the practice. They don't have to wait on the phone line. There's a really clear audit trail of all prescriptions, so less errors by people having to note down and potentially making mistakes when they then input that into the clinical system. I think that there's other kind of side benefit, which is that if you're interested in other parts of the NHS app functionality, by getting patients familiar with this, it can help them to then start to use other areas of it. We know that the NHS app is a big priority area for investment within NHS Digital, so we can expect there to be future functionality and development. So this is a good opportunity to get more patients to use it now for the kind of long term. And yeah, I'll ask Laura if there's anything else from your perspective you wanted to add in.
Yeah, again, just echoing everything that you've said, and I was quite interested to speak to our prescribing pharmacists in the practice who used to work at Tower Hamlets, where I think it was sort of it was more normal that the patients were accessing repeat prescriptions on the NHS app, and I was trying to work out what benefits she saw to that, but also she spoke to the reception team at our practice as well. And I think that for the pharmacist, it does seem that they potentially get less knocks on the door finding out what's happening about the prescription. And receptionists certainly at our practice say that a lot of the people who are lined up at the front desk are asking questions about the prescriptions if they haven't done it on the NHS app, because they will tend to get a notification on the NHS app, and it's being developed as well, the app, about messages about when the prescription has been issued, but certainly as well in terms of the admin time, that manual putting it into the system and the potential mistakes that can happen. I think that is quite a big plus to this. So it's just quite interesting at seeing it from the other side.
Thanks, Laura. What I'm going to go on now is just give a quick overview of how this will work for the patient and the practice, and then share some data around the previous pilot that we've done, what the impact of that was, and just to give people a sense of the current situation in Newham. So in order for a patient to be able to use the repeat prescription functionality, they will of course need to download and install the app. They'll need to kind of connect to their surgery, entering an email password and email address and password, and then they will need to verify their identity, and they can do that in one of two ways. So the first way is they can, without having to kind of get in touch with the practice, if they've got any form of photo ID, typically a driving license or a passport, they can upload that and that will get approved. If they don't want to do that or they can't do that for any reason, they can ask for a linkage key from the practice in the same way as other online services they need to get enabled onto for that. Once that happens, the patient will need to wait for up to 2 hours, typically for the kind of checks to go through, and then they're able to use their NHS login. From that point, they can connect to the surgery, and if they have repeat prescriptions, when they log in, they'll be able to see those repeat prescriptions and request them. When they request them, they can also nominate a pharmacy to pick that up pick up the prescriptions when they're ready. So it's a really simple and streamlined process. And for any practices that are interested in this project, one of the first things we'll do is kind of walk you through this and encourage everyone in the practice to go through this kind of dummy process, because it is kind of really very straightforward and simple. If you can move on to the next few slides, Maggie, that'd be great. Not the next one, and the next one after that, please, that'd be great. So this project, we started off with a small scale pilot in Tower Hamlets, where we worked with Network 5 within Tower Hamlets. And ultimately, this project is providing some light touch support to a PCN to support the practices within that PCN to increase usage by running targeted communications campaigns. It's relatively low effort for the practice because actually there's lots of materials out there which already exist. And really what we're trying to do is provide some structure, some focus for champions within each practice to kind of manage this communications campaign and get more patients to use the app. So when we ran this pilot in Tower Hamlets, here are some of the results. If you go to the next slide, please, Maggie. So overall, we saw prescription requests increase from 7% to 12%. And also we saw an increase in the number of NHS app registrations as well. So both getting more patients onto the NHS app, but also them to use a specific functionality. And then if you go into the next slide, Maggie, and specifically one of the practices, there was varied performance across varied outcomes from the different practices, but the kind of leading practice, Harley Grove, they were able to increase from 6% to 20% of requests coming through the NHS app. So quite a big increase. And if you think about all of the touch points then that are avoided in the reception, you can understand the kind of time that will be saved through that increase. If you go on to the next slide. So we've done a bit of analysis in Newham just to understand what's the current state of play. So how many repeat prescriptions are being ordered online? That's either through the NHS app or patient access. And if we go to the next slide, I think, Laura, you can talk me through this.
Yeah, so you can see there's quite a varied amount of sort of use of the app across the PCNs. We thought it was quite useful to split it across the PCNs. We do have the data on the practices if anyone is interested in that at all, but especially because we want to work with PCNs ideally. One thing I want to point out is that this isn't just about, this isn't all online requesting of medication. Like Joe said, it doesn't talk about the ones by EMIS or AccuRx, which again is helpful to the patient. They can still order it online, but those ones do have that impact on the practice. So again, if we're thinking about saving time and saving patients ringing up, wondering about it, trying to mitigate mistakes, that's why we're sort of trying to promote the repeat prescribing on the NHS app instead. I think that this has all been raised recently by people downloading the app for their COVID vaccination status. But you can see some areas do have more patients signed up than not. So it's just about looking at that, seeing if it is something that would work for you and your practice and you and your patients. Next slide, please. Joe, do you want to take over here? Sure. So, and just for reference, so the mean kind of average across Newham is currently, I think, 9.5%, and in Tower Hamlets it's around 16%. So there's no kind of right target that we're trying to get boroughs or PCNs to, but it's just to kind of give a sense of what's possible. So in terms of the support, I'll be relatively brief. So we're thinking this will take
we've lost Joe, haven't we?
Yeah. Is it worth taking the questions, Nadeem, and whether Laura can help with them, and obviously, hopefully, might be back with us. Oh,
There you go.
Hi, can you
Back.
can you hear me now?
Yeah.
Sorry about that. So just to give you an outline of the support that's on offer, it will be broken down into 6 meetings, beginning with working with the PCN manager, and then we'd like to work with identified champions from each of the practices that are taking part. And over those 12 weeks, we'll hold 6 meetings in which we'll help each practice to understand the data, help them to understand how they can firstly get the practice to understand more about the NHS app, so the different training and kind of exercises that are available. We'll then kind of share what's worked in other boroughs in terms of communication campaigns, largely SMS campaigns, but also engagements with the PPG. We've also been working with Healthwatch, so can share some of their learnings around how to engage patients in improving digital access. And then we'll be effectively working with the practice champions to try out different communication campaigns, and then measuring the results and being able to share with them the results of those different activities, so that there's a kind of an element of quality improvement, ongoing improvement. It's definitely a marathon, not a sprint, so we're kind of expecting that there'll be ongoing activity, but we just really want to get kick-started with some focused looking at data, trying out new things and seeing how that impacts usage of the app. I will move on to the next slide, please. Right. Okay. Yeah. So we've done a kind of risk analysis for this project, and just so that this isn't a silver bullet, and so we know that it's not going to be suitable for all patients, and so that's why we're working with Healthwatch to understand the best ways to communicate with different groups that might be less likely to engage with digital channels, and we're hoping that by moving more requests online, it will mean that phone lines are freed up to support those who, for whatever reason, will never be able to use the NHS app. We know that it's a really busy time in general practice. Practice capacity is limited. That's why we try to design this approach to be as light touch as possible. I mentioned already, there's lots of resources that already exist. There's not that much work that needs to happen at the practice. It's more about taking something that exists and just tailoring it for your practice. And we're also looking at and interested in, particularly for the first couple of PCNs that we work with, just exploring other ways that we can communicate out in the community that don't require the practice, that we can kind of explore, whether that's involving some of the digital champions that have been recruited at a NEL level, for an example, and how they might support this. Also, if you're a PCN manager and you're interested, but you think that it might not be appropriate for all of your practices, we're happy to kind of work with the PCN, so long as roughly around 3 practices are able to support that. Just looking at the questions that, sorry.
Yeah, we've got some. Is the presentation finished, Laura?
Yeah,
We've
this
got,
part, so we can take questions now. Yeah.
Yeah, so Wax followed by Bobby. And there are a few questions. Maybe we can have a look at those and see if you can answer them. If not, maybe get back to us and we can send out the answers. Would that be all right?
Yeah,
Yeah,
thanks,
happy
Nadeem.
to take them now.
Yeah, thanks, Nadeem. We, in that table, Laura, that you presented, North Newham is where we are, and that's, so we, for 1.5 years, have been, when people come in for their COVID vaccination, get them to download the app. Because obviously they need it for this.
Prescriptions are ordered online through the app. Everyone else in is around 10-12%. We're 9%.
Anil, can you unmute, please?
So we've been, so it's quite labour intensive, Laura, and I was just wondering, very briefly, could you tell us how, you asked the practice to increase just downloading the app? Because I can tell you now, 1 in 2 patients, we have to stand there with them, help them take the video, say the numbers, etc., etc. It's not straightforward, and it's an involved process. And then once they've done that, they need to, of course, open up the links with the EMIS system as well. So you need to give your approval for them to start for their stuff to be shared and all that kind of stuff. So I don't know, were there any quick tips that you had that worked in Tower Hamlets to getting that app downloaded? Because that's the big hurdle, really, to be honest. The other bit is all right.
Okay, thanks, Max. Bobby?
Hi, yeah, my question was basically around, I think Joe mentioned that there was a particular demographic of patients who are digitally excluded. They might not be using the NHS app, but I just wanted to know whether or not it's being promoted to practices that the NHS app isn't the only way to access the NHS account, and this can be accessed via a web browser, which they might be more comfortable in doing, and whether that's been promoted to practices and onwards being promoted to patients as an alternative to the NHS app, and whether those patients who are ordering those repeat prescriptions through a web browser on their NHS account, are those figures reflected in the data that was presented in those slides from Joseph?
So in terms of, Wax's question, I hear you, and I think it's not that we're going to try and say we need to, or we want to aim for a certain number. We just want to get as many as possible. But again, it's like what Joe said, it's a marathon and not a sprint, and it's about just the ideas of doing that, but also talking about the digital champions, which I think someone else has asked a question about how they potentially could work. They are a relatively new role in NEL, and their full remit hasn't been completely agreed, but certainly we've had ones get in touch with our practice, and the way we envisage that they could come is actually come down to the practice, be there with the iPads, be there at the desk, and actually be helping patients. But like what Joe was saying, it's not just about the practice doing this. We're actually looking at this in terms of further people being able to help, external people advertising this at the pharmacy. We're looking at Health Watcher trying to help us look at different ideas. Can this be advertised in other places where lots of patients go? So it's hopefully not just all on the practice, but I hear what you're saying in terms of just understanding it all. But again, that's about the comms and the teaching. And then what Bobby was asking about the numbers via the web browser, I'm not sure about that in terms of whether those are counted or not. Joe might be able to tell us more about that, and certainly more about what happened at Tower Hamlets.
Okay.
Yeah, sure. So just to say on the kind of the data, so that data comes from the POMI dashboard, the Patient Online Management Information Dashboard, which covers all online requests. So not just the NHS app, any online provider, so also patient access would be included within that data. And in terms of the other things that Tower Hamlets have done, it was largely a combination of kind of SMS campaigns and then thinking about the different touch points and encouraging patients. In terms of the linkage key, as I mentioned before, I think that's only required when the patient isn't able to use photo ID to kind of auto register themselves. And I think it's about this project is helping practices to look at their patient demographics and thinking about who they want to target first. It might not be that you're going to try and get every single patient online first or using the app. There might be certain populations that are easier to kind of target, and by shifting them to increase usage will save time for the practice. So I think that's kind of part of what we'll be working with practices to do.
Thank you. Anil?
Oh, I think Laura answered the question. I think it's a great project, and I think it's really going to revolutionise us, and a bit of healthy competition might do us good. So if we potentially set Newham North as, you know, the aspiration target, if they can achieve it, we've got a very similar population across the borough. It might be something to consider for an SNS for us for April next year, because this really will save time at reception, but also for the patients. But the transcribing of drugs and the drug errors that happen at reception, which we know about, when the receptionist is trying to use an online form, trying to look for the drug, it's a slightly different dose, different same thing. We know that the errors are happening, and this will really reduce that. So well done, Laura, on getting this together for Newham. But let's try and make it a PCN approach kind of competition of some sort, even for the next 6 months, and let's get everyone on board and really make it work and happen.
Thanks, Anil. Yeah, I agree. It's a really good quality improvement project and potentially lots of efficiencies to be gained, and maybe the direction of travel, or although you never know. I suppose it's how we do it really, and how we, in a difficult time, Laura, with so many pressures, and we're going to come on to kind of polio and all the other vaccinations we need to do in the next 6 weeks, how we open up that kind of capacity for more medium-term gain. I don't know if Jenny's got any resource that you can get hold of, or any digital leads.
Not sure about that aspect. And just
Um,
before we finish, can I just ask, can Charlie just have a couple of minutes just to talk about another project that we're doing? We will come back and present it, but
So
just so people
But
know.
you want volunteers, and who do they contact? Do they contact yourself or Joe, or?
Yeah, Joe's going to, say that
And
first,
we
sorry.
want practice managers, and I can see Manuel had his hand up as well. So maybe Manuel, if you can contact Laura and Joe quite soon. And the questions in the chat bar, Laura, as well. Have a quick look and see if
Yeah,
there's
let
any
me
you
have a
can
quick
give
look.
quick answers to. There's quite a few.
So, Greg, so what is the split between percentage age ordered online and patients ordering in person at the surgery? We asked the head honcho, the one that we know about from the NHS app, about these age ranges of the percentages, and he couldn't give us those figures. In terms of, I guess, us trying to find out what's happening locally, it might just be a pen and paper audit, but we don't have those figures. We're not able to search for them. We did ask for them. And I think Imrana asked about NHS app and patient access. Yes, you're right. We've done this in terms of the dummy patients and talking to the practices. Does it make any difference for the staff whether it's done via patient access and NHS app? It doesn't seem to make any difference at the moment, but the direction of travel is for the NHS app. And I think all of the improvements are going to come through there in terms of getting a text when it's ready and things like that. So I think that if you've got a choice between the two, it's probably the NHS app that has been more pushed to go towards. And oh no, online requests be auto-coded in EMIS. I think so. Joe, you might know better than me about that. I'm pretty sure we would be able to match that up because, like you say, it's quite important to be able to follow that when things have been requested, but I'm not sure.
Okay, thanks. And you want to mention the other project, Joe, if you could.
Yeah, Charlie's just going to come in about that very quickly. Thanks.
Yeah. Okay, thank you. Yeah, just literally 1 or 2 minutes. So I work alongside Joe. My name is Charlie, and I'm also in the Digital Accelerator Change team. And another program we're offering is called Enhanced Demand and Capacity. We're going to try and bring it back to this meeting in a month's time with much more information. I've put a very brief summary in the chat, so you can have a look at that. There's a link in there as well to a longer presentation. But basically, we go into a practice, a facilitator and a GP who've both been trained in delivering the support. We look at your appointment system, understand how it's working and how to make it work efficiently and configure the slot types, etc. And then we get some data out of Edenbridge by configuring the reports in there, and then use that to look at the capacity and demand data in a special tool. And hopefully the idea of that is you can do some reliable planning based on accurate data that you can understand and make sense to you, rather than, I think some practices have to guess at what's going on. So far, it's been piloted in City and Hackney, and a third of the practices have done it there. And they're kind of certainly getting a much greater understanding of what's happening within their systems, being able to make decisions that they're confident about. So we'll come back to you with this next time. Laura's done a bit of work in her practice and also in her practice, so I'm not sure if she wanted to give it a kind of quick nod of endorsement or anything else.
I just wanted to say, obviously, I think most of you know we've done lots of work at Tollgate for our appointment system, and we're constantly trying to improve it and improve access and understand it more. And we've learned a lot so far from Nisha Patel and Charlie and the team about how to actually capture that data. Even if you go into Edenbridge and you go, I don't really understand what's going on here, about lifting that out and actually planning it. You know, planning your locum sessions, planning how many people you can have on leave. We're doing work in our practice on that. And it's working in a lot of City and Hackney practices as well at the moment. So ask any questions along the way, but we will come back to present some more.
I'm going to have to move on a bit, Laura. Maybe if
That's
you can
fine.
contact NHC, we've got a couple of new people coming in for comms, and if practices and PCNs need help with comms websites, then I think we'll be able to help. And Charles will come back maybe at a future meeting with a bit more detail and do it a bit of justice. Thank you for that. I'm just going to move on to hi Madalena, just to give us a brief update on Stoptober. Madalena is one of our LBN colleagues. Hi.
Hi everyone. Yeah, it looked different for the first time. Hi everyone. For those of you who know me, I've been here before. Public Health Commissioner, Madalena Pop, working in London Borough of Newham with my colleague Jyoti. Thank you very much for the opportunity to talk to you. Very short, very brief. We know Stoptober is approaching, so we just want to very quickly touch base on the smoking cessation activity in the borough. Very shortly, as a background of our service, we offer 4 and up to 12 weeks support for smokers and smokeless tobacco, so chewing tobacco as well. We have expert advisor and a very, very good feedback from our service users. We use NRT, so we have the inhalators, the patches, the gum, and very popular, the e-cigarettes. That's even 20% of the treatment use in our service users, so it's quite popular. So you can, obviously you can refer residents to our service. They can also refer themselves, so you can refer them via EMIS, and they can also be referred through various routes. On the next slide, it's a, sorry. Yeah, it's just a quick reminder of our priority groups. So basically, obviously the service is for general population, but we encourage you to refer people with underlying conditions, so COPD, asthma, cancer, diabetes, mental illness, moderate and severe, Eastern European population having high rates of smoking, routine and manual workers, young people under 25 and looked after children, pregnant smokers and their partners, and clients in acute settings. But we do receive referrals from bars from them. Yeah, absolutely. That was the next slide. I just saw the question in the chat. So this is the helpline. We have the email, text or WhatsApp. So basically anything works. You can just, the resident, sorry, not you, you as well, of course. So basically they will answer the text in 24 hours. So any request, and you'll be picked up by a smoking advisor. We do also started the face-to-face sessions as well. So for those who really want to meet face-to-face, that's possible now. And we do the CO readings as well now because COVID permits. And the next slide, please. Yeah, this is just a very brief picture of the current situation in Newham. Basically, you have the need as in smokers in the barrow on the right hand side, and then the activity as in quits and our provision. As you can see, we have a very high need on the North Village, Beckton, so Southeast Newham area, and a lower activities, which means that we have to be more active in those areas where we have high rates of smoking, but lower rates of provision. So obviously encourage you to refer more in. If you know you have smokers that are really willing to quit, please do refer them to the service, especially now because the context is really suitable for this. So what I would really like to do is actually try to cover the whole borough, because I know there are some top, I would say, GP surgery that always refer. So I would really like to engage, obviously, with everyone. So to cover the whole borough, all LSOA, all wards where we have as well high rates of smoking. So for this October, we will focus on the priority groups that basically were less engaging in the past, which is Eastern European population and routine and manual workers. We will obviously raise awareness about the danger of smoking, about Quit Well Newham, and we will have 4 or 5 even outreach events where residents can actually go and talk with the advisors. And this will be concentrated around Docklands, Beckton, Canning Town, so those areas where we identify the high rates of smokers but lower provision. So yeah, as I said, basically we'll focus on Eastern European population, Lithuanian and Romania, the first 2 most spoken languages, and the population in Newham, and routine and manual workers with a high prevalence as well, and a low registration in the service. And as I said, residents living in Docklands, Canning Town, and Beckton. So this is the focus on this October. Obviously, we focus on everyone, but with the EDB. So yeah, as I said, outreach events, we'll have an outside North Village Library, at a construction site, Beckton DLR, Custom House, East Ham, at also a Romanian restaurant, And we will display posters of our no smoking competition. And obviously we will distribute as usual leaflets and poster to your GP practices and pharmacies with the contact details of the service. As I mentioned, CO monitors will present at the events, so residents can actually have their CO monitor. And we also introduce a regular face-to-face session in 2 of the libraries, Beckton and North Village, apart from the 4 GP surgeries we already have smoking cessation clinics. And as an ending note, just want to make sure that the GP notification works. As we know, we introduced earlier in the year. So you should receive a notification when a person is registered to the service with the medication used and also with the outcome appointment. So I would really like you to let me know if that works in practice. And yes, that's pretty much it. October summarized. Any questions, any comments, please do ask.
Thank you, Madeleine. A really helpful reminder. And as you said, it's a good reminder to signpost patients to services locally, and it's kind of part of our opportunistic kind of health promotion. And this is the time of year when we do it and we push it a bit more. Imran has asked a couple of questions about certificates and about when the service started. I think the service has been going on for a number of years, hasn't it?
So the specialist service started in January 2021. We did have the pharmacy service, but the specialist one started in 2021 January. Can see interested in this project for sorry, my chat is.
There was Madalena, there was a specific question about whether people get a certificate having completed the course. Just because Imrana said that they'd had a specific request from a fertility clinic for that evidence.
A course? You mean the GPs or?
Patients
Yeah,
will get one.
just to jump in, it was a patient who's on under fertility clinic, and they won't be put on an IVF list until her partner's got a certificate that they have stopped smoking. So I mean, so my 1 and 2 question was linked because this patient had walked around, I think, the entirety of Newham pharmacies and couldn't find anyone to do the stop smoking.
Absolutely, yeah. I mean, this is probably a document that our provider can do. I really just a headed letter probably with a signature. So that's definitely something. I mean, he or she has to register first with the service and obviously go to treatment. And then, yeah, we don't do certificates, but I think if there is a need for that, we can definitely do something like that. I don't see why not.
Okay, thank you. Can't see any other questions, Madalena, so thank you for that really nice reminder, and we'll carry on pushing for smoking cessation, which is obviously really important. Thank you.
Yeah, especially now. Thank you so much. Thank you.
And we'll send out the slides and the information as well.
Yep, absolutely.
Thanks.
Thank you.
Should we move on to Wax? Hi, Wax. Wax is our also our NEL immunisation lead. He's going to talk to us a bit about polio, COVID, flu. Any other vaccines you're going to talk about, Wax?
Let's see how we go. Has something come up on your screens? And I'm glad Jenny and Greg, is Greg still here as well? So they can correct me if I'm wrong. Sorry, that's the GP's way of presenting, not a manager's way of presenting. But yeah, I wear a different hat these days as well. I'm the NEL clinical lead for IMS and have been sort of just before Christmas gone. How much time have we got, Nadine? I don't want to take too much time.
About 10 minutes.
All right, no problem. First of all, let's start with polio. I wanted to say absolutely well done to all the practices. On that screen you can see the data. That was the second cut of data from the 5th of September. I think actually it goes back to Friday, but we were shared it on Monday. And well done. So practices, that's a Newham line there highlighted, but practices getting on with the polio and absolutely recognise that it's a really tough task. And you can see where we are in terms of eligible children, invitations, declines, and vaccinations. And when that cut of data comes again, I'll put that in our WhatsApp and also share it through other means as well, so you're able to see it. see the practice breakdown. I just wanted to say absolutely well done, because it is really, really difficult right now. Everybody's back at school, you know, the desks are busy, everybody's busy, workflow's busy, and finding time to do an emergency program like this is not easy. Or be part of an emergency program is not easy. Invites. The invite column there in that table is pretty important. We've had, is that just come up on your screen as well? Yeah, sorry, let me just, oh, okay, somebody's responded, sorry. So I think, sounds like somebody's collapsed outside, but somebody has gone, sorry, I will carry on, okay. Yeah, so invites, we had a conversation on our WhatsApp group around coding and retrospectively coding the invites that you all have sent out via AccuRx. Does anybody have any questions around that, or having any issues? And what I've sort of said, and what we said, Jenny, during the week, was that at Practice Managers Forum, some of these technical kind of questions, these could be supported with 5 minutes of just like a quick demonstration. And I mean, many of the practices have got individuals that could give 5 minutes just to show how they've managed to do it. But it's really, really, really easy to retrospectively add those invitations, and it's an important metric that NHS England are collecting. Manuel?
Yeah, my quick question is, because a letter has already been sent out by NHS, can that be considered as a first invite?
No. So the NHS England have sent out letters and communications to those eligible. The first invite that we're collecting is the one that we do from Practice Manual.
Okay, thanks.
Yeah. Okay, so support for practices. So there's been lots of conversation around support for practices as well, and Greg's here on the call. Okay, so the kind of things that we're looking up, and I shared this with you all on WhatsApp earlier today, was that so the roving team continuing their fantastic support of these very, very sort of challenging programs, and really getting to those that are hard to reach as well. And Helen and the team have been going around to their practices and supporting that polio uptake, as well as doing call recall. Do reach out to them. Karen, I'm quite sure that a message has gone out, hasn't it?
Yeah, can I chip in, Wax, to say, so
yeah.
I think what we thought we might do with Practice's sort of agreement is we might do a bit of a ring round next week, see how you're getting on, because we do know that, you know, there's so much pressure. I'm not 100% sure that NHC can fill all the gaps, but we'll certainly see what we can do to augment some additional support, and if necessary we can perhaps flag it up to commissioners if we think there's a real challenge going on as well. So yeah, we'll reach out to you next week and just see how people are getting on.
Yeah,
but there has been some outreach clinics, is that correct, Karen?
Yeah, there've been a few, and I know so Helen was talking with Carolyn in South One. I know, Wax, you've been doing stuff. I know Abbey Road have been doing Saturday clinics, so it's going on, but we're also just aware how much pressure there is.
Yeah, we're all just kind of chipping in, and things are moving along, as you can see from that table, and actually kind of bottoming down into like a business as usually kind of baseline kind of situation. But as always, NHC, thank you so much for your support. I did say during the call, you know, there is a time where we can't, you know, pivot towards NHC, and we, you know, and we need to work on supporting the development of practices to be in the position, or be in a position to be able to support this kind of situation when it arises. Payment on top of the iOS. So lots of conversations today, yesterday, and over. And Greg will be able to confirm. But you know, I think we're coming close to, fingers crossed, some kind of agreement around some enhancement on the item of service of £10 and 6p, more pounds than pence, but anything I think can support us with some marginal gains around this, and I'm quite sure the NEL team are in conversations with LMC around this as well, and Greg can say yay or nay. Right, yeah, so non-primary care based clinics. I circulated to you all a link which identifies non-primary care based clinics for 6 to 9 year olds at Westfield. They're open Monday to Saturday. And I'll put that link in the chat bar when I've finished this little segment. You know, it's not just about primary care. That assumption that these public health kind of situations are just about primary care. Yes, we're good at it, but absolutely we need to recognise that we are stretched doing so many things, and it's a difficult time of year for everybody, and it needs more than just primary care to respond to this kind of situation. And that's an important message going back. Jenny, hands up.
Yeah, so just to confirm that the Westfield service is for boosters only. It's not a walk-in service, so people do need to book, and the sessions are virtually empty at the moment, so lots of capacity there.
Yeah, and I've just put it in the chat bar for you as well, and I'd circulated that before, and you will also be getting an email with that as well.
But
And
Jenny,
also,
do they, when they do all these appointments and they open up Westfield, do they do anything about call and recall, or is that kind of left to practices to do?
No, it's left to practices to do. They don't have that information, do they?
So who's running the service?
Elft.
So Elft are running it, but we have to do the call and the recall.
Nadeem,
And signpost.
So the way it is, Nadeem, so we've tried across this one, and you know, in the future we hope to be in a better situation with sort of being able to identify and list. That would be kind of nirvana in this kind of situation, but the fact of the matter is GP holds those lists and absolutely have access to who is eligible and who isn't, and we have to kind of do our bit in that. But it's not an ideal kind of way, because we want to be in a much more kind of tech savvy solution to that call kind of recall. And we've sent out, I think the email would have gone out or is going out today of a text with that link in, and hopefully practices can support when they text out Manuel that first invite or second invite or third invite even, and use some of these extra clinics that are being put on. Caroline's asked, how will they inform us and will they be able to code? Yeah, so Elft use Chiz or a different kind of system. They collect that information. That, my understanding, Jenny, if you correct me if I'm wrong, goes back into the GP record every Monday for Newham EMIS practices. I've triple checked that and quadruple checked that. That is happening and that is contributing to our numbers. And then all of that information goes back to Chiz, then up through something called System C and ends up with NHS England, not the patient identifier information, the numbers. And so, yeah, so, Greg's put in there, good question, schools enroll or lack of for Vaccination UK. So Greg, so Vaccination UK are doing some clinics in Tower Hamlets and City in Hackney, and the offer has also gone out to Newham as well. So I know, and I've just seen some email traffic, Tower Hamlets clinics on the 15th, City in Hackney clinics, they did have one, they weren't very busy. And what we're trying to do is to make sure we get the comms and engagement right around that to make use of this extra support that it is. Again, moving away from that assumption that this is just a primary care problem and really getting everybody involved.
All right, do you want to, we're just running a little bit late. So in terms of, do you want to just summarize very quickly? I get the bit about public health should be done in schools.
No problem. And the other thing I think what we wanted to
so in terms of just to summarize primary care as well going forward, do you want to give us a bit of a summary? So
yeah, so we've got access to an eligible population. I'll tell you what we're doing in our practice. We've texted everybody and we're trying to get as many of those eligible in for polio, as is Sabir, as is Upton Lane, as is X practice, as is Y practice, as is Z practice. Absolutely recognise that the capacity is different. We all have a different staff makeup. This program calls for a certain kind of workforce, etc., and stuff like that. Everybody has different kind of pressures, but the expectation is to get these young people in for their polio vaccination. The last thing we want is a case of paralysis that is
Okay,
the worry.
thanks.
But so able to text out to practices, get them invited into clinics. If you can't put on the clinics, send a link out to the other clinics, etc., etc., etc. Does that answer your question, Nadeem, on that?
Kind of. Karen, in terms of our role or NHC role, anything you want to kind of add? Because I know there's some appointments and extended hours. Is that correct, or am I not
Yeah,
right?
there's some addition. Yeah, there are some appointments at the moment in the extended access offer during the week, and also the roving team are able to do some support as well, and they're just building up some additional capacity for call and recall. So as I say, we'll reach out to all the practices next week and just try and find out if there's any other sort of significant gaps. But I do recognise that people have got a lot going on.
Yeah, a big ask, and we can only try, I suppose.
Yeah, and so there's two other things. So with all of this, and it's clear we don't have the workforce, so there's plenty of conversation now happening around looking at, and I'm not going to say too much, but expanding that ARS portfolio and actually being able to flex that. So that conversation happened about an hour ago with the relevant people at NHS England, and we'll feed back as soon as that happens. Certainly what's worked for us here is that transformation kind of manager kind of role here, who has been able to sift away stuff from HCAs, nurses, etc., to be able to deliver do the needlework, etc., and stuff like that. So just an example of the kind of conversations we're having. Oh, and there was one other thing with the polio, and actually relevant to everything else as well, is the ability to step down of stuff. I'm going to give an ask to you all, and I communicate this on the WhatsApp. What would you be able to step down in the next 4 weeks safely, or what would you want to be able to step down aside from quaff? And you got to give me a reasonable challenge here, something realistic locally that we would be able to step down to be able to support uptake here. And that's an ask that's gone out to all the boroughs, and we'll be feeding back to Jagan and Mark and the ICB and NHS England colleagues as to what is in the art of the possible. To be honest, I think some of this will be able to locally flex. So think about local things that we do, that we would be able to step down, that don't impact patient care, that you want to step down to be able to be more involved in this program, if that's what it takes. If that's what it takes. So it's
maybe some options. Maybe you can have some options that we can discuss at another meeting.
Yeah, I mean, I've said from our practice, I've fed back already, looking at a couple of the meds ops audits. If that frees up pharmacists and some of the admin team for 2 days, that means we can get another 100 jabs done. If each practice in NEL does another 50 jabs, 50 times 300 or whatever is, you do the maths yourself. Yeah, 10 times 300, 3,000 times 5. Yeah, so you do the maths yourself. So we could potentially get very, very close to that 50% uptake, and then the 100% uptake as well.
Thank you,
Nadeem, if that was okay, and I'll take questions afterwards. I've scrolled on the screen. Flu searches are out there. I'm quite sure most have downloaded them. The flu KEG have done a really, really nice flu guide template, and I'll share the link for that, but I've shared it on these notes as well. And then with COVAX, look, the program started this week with care homes and care home staff. Many thanks again to NHC and the roving team to going around and doing all the work and stuff like that. Next week, over 75s. So on the 12th of September, over 75s have been invited to use MBS and various other means to come and get their COVID boosters. Now, COVID searches are kept in that folder there. Can you see searches? Copy that folder down into your thing. You might not have probably done that yet. Autumn COVID booster campaign V1 into your practice domain. Jenny, that's another one of those technical things that I think is helpful for the practice managers forum, and we can show how that's done. Certainly we did that today here at the practice, and we've sent a text out to actually, I'm going to be cheeky and I'm going to say we sent it out to more than just over 75s. We sent it out to over 65s as well, because that kind of matches our flu texting, because we haven't got any flus for over 65 years. We have for
thanks, Mike.
Yeah. Okay, so Karen, I'm happy to share these notes, etc., and I put some links in the chat bar. And there's also a link to the Newham vaccine schedule. We'll be sharing out that Newham vaccine schedule as well. It's on one of my screens at the moment, but Karen, if I'm right, SLG, Essex Lodge, Woodgrange, Westfield, Anywhere else anybody else can find, and Westbury.
Okay, thanks, Max. We're a bit over time now. Jenny, if you could just come in and just also take the feedback about because it happened with COVID that they had a site and no one, it was empty a lot of the time. So I'm not sure how that commissioning decision gets made, but I'm sure that resource can be better spent in other ways a lot of the time. Do you want to?
I think, yeah, so I think, to be fair, Elft have vaccinated many thousands of patients, as have all of our sites across northeast London. So I think it's a bit unfair to suggest that they're not potentially pulling their weight. So there has been a particular challenge around booking patients into the capacity that's available, and a very big challenge around how poor the comms has been around this particular program. So not only to practice staff so that they understand what the ask is, but also to patients, and in part that has been due to not necessarily knowing. So inviting patients is one thing. We need to be able to signpost them to somewhere is the other thing, and we need to then have a coherent booking arrangement for them.
But I mean,
so
you did mention there were
so
empty
be careful
yourself,
what you
Jenny.
wish for, because actually that Westfield site is due to close
Sure.
in the very near future.
But if it's not got many patients, then it's
Well,
probably not.
so I'm saying for polio, the booking arrangements have not been established well enough for us to have maximised booking of it.
No. All right, thanks everyone. We'll stop there anyway. I think we've got a lot to sort out with the vaccines in the next few weeks, though, and I know Karen and Jenny will all come together and see how we can proceed.
Nadine, can I just say one important thing? We need
Wax, we need to move on.
To get this right. I'll tell you why we need to get this right. This is absolutely a priority, because it's not just polio, COVID and flu. It's going to be MMR as well, and we'll hear about that in the next couple of weeks. So we absolutely need to get this organisation right and think about our priorities and what we're looking at delivering going forward.
Thank you. Thanks, Wax. We'll come back to this, I'm sure. Thank you. CQC and Sabir. Sorry, we've only got about 10 minutes, Sabir, but
no, that's all right.
We can continue after, and people can stay on if needed.
No problem. So what exactly? I just wanted to go through quickly that what is the new single assessment framework coming from the CQC, and just what actually we need to prepare from now onwards, because we already had a preliminary meeting with a representative from Newham, as I went, Isabella from Tower Hamlet, and somebody from Redbridge, to a test and learn session to see what kind of question a quality statement can be formulated. So I'll just, it's really a 4-hour session, but I just wanted to do one area only called safety, and this is the new approach that coming from January 2023, and I'm so glad that Jenny and Greg is here, because it's very important to know exactly what happened, this kind of quality statement. So if I go to the first slide, so what exactly they're trying to do, it's a single assessment framework where all the people will be asked the same question. Is it a service specific and the role specific? So say, for example, Karen will ask one kind of questions, and say another question will be asked to the Jenny from the same background to see what exactly perspective of how they're working collaborative. The whole point of doing it to promote this collaborative working, and the basic structure they're looking for here for collaborative working is the transparency, accountability, and interdependency. So if you see here what I put down here, that this applies to all providers, including GP provider, community provider, out of hours, everybody. It also local authorities like LBNs and other provider, also either ICB or ICS, they will be also asked the same question. The thing that I put down in the red, that question came from that meeting called Test and Learn, and we find very difficult to answer this question. The question is how the ICS and ICB engages PC and CD, Federation representative, LBN community services in population health management and BARA-based service delivery. So there is a lot of evidence we need to collect from now onwards that how this really norming forming happening regarding the ICB, and how the other stakeholders are really engaged. It has to be a meaningful collaboration. It's not like what we used to do before called tokenism. It has to be really endorsed by everybody like PH and CD. There will be interview to ask, did the ICB discuss with about polio vaccination delivery? Is there any evidence you can show the minutes of the meeting or any recording that where your opinion been heard, or it probably even LMC might ask the same question, are you getting involved with this kind of activity? So there will be a lot of collaborative interdependency has to be proved that time. The CQC hasn't changed anything about their questions, and the framework is only to do for everyone, but the questions remain same. So there will be 5 questions on safe, effective, caring, as you know, this is already we know everything. Then there's a 4 rating scale. So say, for example, good, outstanding. So each questions will be a quality statement. So say, for example, if the polio vaccine delivered collaboratively, can you give an example how you engage other stakeholders? So those kind of questions they will ask when come for those kind of visits. So what exactly they're looking for here, that how the GP practices is working with ICB and how they really get their voice been heard, the patient voice been heard, the LBN voice been heard. So everything is the framework, the quality statements are going to just emerge out the way the service are developing now. It's not the box standard we had in the past. It's all next 2 months. There will be more test and learn event will happen, and then they will devise those kind of quality statement that how good safety looks like. So I'm just going to give you a bit of example here. So if you see there, these are all coming from what we call the Health and Social Care Act to 2009, when the CQC came to the scene, replacing healthcare commissions. Now CQC taken over all is a joint commissioning by Social and Healthcare. So they are going to really implement Health and Social Care Act at 2009. If you see all these things that the green thing, the regulation 12, 16, 17, these are the 3 regulations usually GP fails. And we need to be very careful that we have safe and treatment. So I can explain later on probably another session when the PLT start that what exactly the safe treatment means and how the commissioner, how the federation, how can PCN can really work together and make any kind of intervention safe and treatment. So then you can see that good governance for everyone, how the interdependency, how they're really accountable to each other, like how the ICB is working, how the PCN working. So what kind of really system in place to make sure that one system is supporting each other under the good governance care. So if you see that the first thing I was going to say, there's a learning culture. You need to prove there's a learning culture. PLT is one way you have to show that there's a learning culture. The same things as safe extended access or something, how this patient will transfer in between the services, how the GP will get involved, who has been seen last night somewhere, and what GP has done when received something from GP Co-op or from the UTC, what exactly the access on, and how, if any problem happens, how the commissioner came forward to redesign the service again. So there it is an iterative process, and you have to constantly show we are really designing the safe system pathway and transition is happening in a seamless way. Then safeguarding is a very important here, because there is always, when there is lots of people working for one patient, there is always a chance to something will get missed. So what kind of watertight system we have to make sure that when the when the adults are seeing in the nursing home, vaccination given in the COVID vaccine, how the system is robust, that if somebody picked up that roving team, there's some kind of elderly neglect happening, how the system picked up something and work together, learn together, and just implement and redesign the service. So safeguarding is very important for the CQC as well. So how you involve the other provider, what kind of feedback that we have get from the access, that is that really make any difference, or is just we just increase another supply in this demand? Is that really make any difference to patient? Are the really patient wanted to see on that time, or is that those time are only taken by the practices core hours? So those kind of really important to focus. Each time we do something, we must have to have an evaluation to make sure that system are working together to give a better care for the patients. The safe environment is all about, as we said, we are having 18 or 17 sites. how the sites are making sure they're safe environment. Are they really infection compliant? Are they have good instruments for the doctor to see? How the doctors have been helped if there is a problem happens. So if it is in Sunday or Saturday, somebody working, is there anybody online from the admin staff who can really deal with those kind of problems? Say, for example, something broke down, or so we need to make sure the system is tight enough to work, hold the system working, because remember, it's a single framework. So there's no way you can say, because Dr. Sands didn't do properly things, that's why the patient suffer. It holds, if one person fails, the whole system fails. So effective staffing, what will happen? We are just increasing one by one new services. What will happen if everybody get flu? What will happen if everybody get COVID? What will happen if there is a flood? So those kind of things we need to have enough staffing, enough contingency plan. We are reviewing each time the way it's coming. I think we are running out of the time. Infection control, obviously, it will be for the all sites. We need to make sure the infection control being then it is not the GP surgery responsibility only. Already the people who are commissioning or using the service, they also have a responsibility to make sure the patients are seen in the right infection control environments. Medicine optimization, how these PCN pharmacies are working, are they supervised, what they're doing, how they're handovering the cases to each other, those kinds of interaction must be there. These are all the regulations that are going to come to implement So this is the only things I need to tell you now, but there will be more training education will happen. As we go, we test and learn, and we develop the quality statement. And as I said, it's everybody's problem. Quality cannot be done in isolations. Thank you.
Thank you, Sabir. Any questions on the chat bar, Karen?
Not specifically Subir, but I'm guessing we're going to have to keep coming back to this. This feels like a huge area of importance.
And you're still providing support, Sabir, where requested, is that correct? And I think you're providing some support currently for some practices, and we're still doing those mock CQC visits on if practices request them, is that correct?
Yes, definitely.
Yeah. And infection control audits are available as well. So
only thing I wanted to tell before I go, please, out of our patient, say for example, I'm in E15, okay? I need to do a search to find out how many patients I have excluding E15, E16, E13. The reason CQC is doing this kind of phone calls now, what is your mechanism of find out these patients who are not getting the flu jab, they are not getting the COVID vaccine, they are not getting the treatments. I know that we can register the patient for far away, but at the end of the day, if you register patient, you cannot just say, because patient is far away, I couldn't do it. It's your responsibility. We need to provide the service. That's why I said to my practice manager, do a search to find out how many patients we have beyond E15, E13, and E16. Rest of our all out of the area of patient, but still, as long as they're registered with our practice, we have a responsibility to deliver the care they need.
No, good point about the kind of pathways between access and the other services and practices. Manuel, quick question.
It's not a question, just going back to one of the examples Subir just raised about the flu vaccination targets, because NHC is actually rolling out the data sets for all these things, and there's also individual supports for the practices to actually improve on those targets, and also record information as per the CQC compliance. So please take that offer, and if you speak to Paul or contact Paul and take the offer, because it's there.
Thank you. Thanks for that, Manuel. Okay, I think that's it. There's no questions, so I think we'll leave it at that. Thank you, Sabir. And see everyone next month. See you.
Thank you, Nadeem. Full agenda.
Bye bye.